The first set of slides was ideally intended to address this issue of has Medicaid paid for what it really wants? In the aggregate, I think that it has, and the payment reforms to nursing facilities in the first part of the decade designed to increase nursing staff ratios, et cetera, to improve quality, and certainly my division of long-term care, Carol Shockley, we've expressly set about to improve and assure nursing home quality across the state. But at the individual provider level, we don't pay for what we really want, outcomes, et cetera, quality. We haven't even really defined that, and our payments are at an average level. The second question is, do we match the level of care, the payment, to need? You describe what you're looking at here. It's a scatter plot. It's the definition of the graph, and it shows nursing homes by their average per diem. You've seen that before. You've seen the vertical axis before, but now what you're looking at along the left to right is you're looking at the Medicaid bed day weighted case mix using MDS data. So here what we've done is to calculate kind of an average level of intensity of service or level of need using MDS data to come up with that. We've computed for each facility their average for their Medicaid recipients, their Medicaid residents. And so now each nursing home is a dot representing in one axis its average reimbursement, and in the other the average level of intensity of service or level of need using the MDS. And what you see is absolutely no relationship at all. None. Not surprising, because that's not how we pay. This actually puts nursing homes in a pretty bad position, because a nursing home has to decide it wants to take the higher needs patient, even though they don't directly get more money for it. And they have to avoid the incentive to take the lower needs patient because it makes them more money. When I talk to physicians, I say exactly the same thing. What do we pay physicians for? To do more procedures, to have more visits, to provide more care. What does the Hippocratic oath that they take when they graduate from medical school and become a physician, what does it pledge? It pledges not to over provide care. We have incentivized physicians since the beginning of insurance time. We've been incentivizing them to do something that their medical ethic tells them not to do, and it's only because they resist that urge that we don't have even more utilization. Same problem here. We are incentivizing the wrong thing, and you see the byproduct of that here. Now, it could be that there are differences in facility or operational costs. Those would almost certainly we would see differences in labor costs or property costs, et cetera. We would see, or taxes, whatever, we would see those, and they would very highly correlate with geography. So you'll see in the green those dots that represent Pulaski County. I believe that's right. And even within those green dots, you still don't see any relationship. So that tells us that the lack of relationship between the needs of the patient and the amount that we're paying on average for a patient is not driven by those costs. And as I said, we're incentivizing the wrong thing. We're not incentivizing the right thing. Again, when I talk to physicians, so you have to understand, we're not picking on nursing facilities. What I've said all over and over again, I want you to hear this. Medicaid as a whole has not paid for what we really want. And we're calling foul on ourselves. And this is exactly the same speech that, that we give to the physicians when we talk about medical episodes or the patient-centered care home. Shame on us for not paying for what we really want. It's easier now because I think the mechanisms to do that require probably some data technology and sophistication we probably didn't have even 10 or 15 years ago, certainly not when the Medicaid program was created in 1966. This is another look at essentially the same thing on slide number 14. Nursing facility billing rates to Medicaid do not show a correlation with assessed level of need. So here we have some data that groups MDS results into resource utilization groups, RUG levels, and we've arrayed RUG levels from lowest to highest. These bars don't represent individual nursing homes. They represent the average reimbursement of Medicaid to individuals, to nursing homes, to all nursing homes for each RUG level. And again, our average reimbursement, our average paid claims to nursing homes does not vary at all with RUG level, or at least not in any meaningful or consistent pattern. So this actually is a performance metric for the program. Okay, the fact that this exists is actually a negative performance indicator for the Medicaid program, and we're going to try to fix that. We have a similar analysis plan for HCBS for the community-based services. We can't actually do that right now because we don't have an MDS form. We don't have a consistent metric or measure of each client's level of need. We will as we begin implementing the universal assessment for community-based services beginning in January, beginning next month, and we'll talk a little about that later. So as we accumulate that data, we will put charts like this together for community-based services as well. My expectation is we will probably see less of a correlation and a slope than we ought to, because we don't really pay quite that way yet. But this is what we have today. The next opportunity that we're looking for, how to help people get to the right setting of care. So here we're going to start talking about process. And so one way to measure the appropriate setting of care is by level of intensity, and under the operating assumption that by and large the higher level of intensity would be treated institutionally and the lesser in the community. That will not always be true. That's actually a policy decision point that we'll have to make at some point. But depending on how you measure low levels of care, and that could vary, and we're trying to show that here. And by these measures, 21 to 30% of nursing facility residents are at low care that could possibly be met in the community. So you see by RUG level again, the RUG groupings at the bottom. We've got 1,238 residents in that lowest level of need. We've got 1,024 at the BA1 level, and there are two dotted lines. The first dotted line to 30% goes all the way over to the PB2 level. I don't know if you can see that dotted line or not. So we're just acknowledging here that we don't have a state policy for, according to RUG levels, what low need is. So we're not able to make that value judgment today. We're not able to label low care, high care in the nursing home in this way yet, because we don't have that kind of policy. That's one of the things we'll need to do in the payment improvement effort. But compared to other states and using the MDS data that we have today, that's what we find. Yeah, here's a question from Little Rock.
David Norseworthy. Dr. Allison, is there any kind of metric, or maybe that's not the right word, but in your evaluation of this, will there be any, from a pragmatic level, with the level of care, take into account the family resources? Because, I mean, obviously, if someone has a wife and 4 children, it's different from someone who's a widow with no kids as far as caring for the family. Is there any evaluation of that with the new assessment instrument, or how are you trying to deal with that?
That actually was the source of conversation internally with the staff 2 hours ago, we did not have a satisfactory answer internally. So I want to register that question. Ideally, we are incorporating the level of external support in the metric of need, so that the metric of need is really a metric of a gap. And a gap is determined both by the intensity of the problems that the individual has or limitations, and by the availability of resources. Let me also add, though, that I hope that you all begin helping us to think about that value judgment. It is a value judgment. What is the relative obligation of society, the state of Arkansas versus family? I am aware that the policies that we put into place, which we hope are there for a long time and need to be there for a long time, because residents of the state of Arkansas need to know what to plan for. They need to know what's going to be there 10 or 15 years from now. And those value judgments about how much extra help we should give someone who does not have family support, etc., highly relevant. I think we do need to take that into account. We're looking for help. Maybe other states have done this in determining how that should factor